Boa tarde, meu nome é Camila Tacal Lopes, eu sou professora da Escola Paulista de Enfermagem da Universidade Federal de São Paulo e sou um dos membros da Rede de Pesquisa em Processo de Enfermagem. Eu serei coordenadora das atividades desta tarde sobre Processo de Enfermagem Avançado, que terá como palestrante a professora doutora Maria Muller-Staub e como debatedoras as professoras doutora Rosemary Santana, da Universidade Federal Fluminense, e Tânia Chianca, da Universidade Federal de Minas Gerais. A doutora Maria Muller-Staub defendeu seu mestrado e seu doutorado a respeito de diagnósticos de enfermagem, foi professora de enfermagem durante muitos anos na Suíça. A sua formação acadêmica foi realizada na Holanda, onde há programas acadêmicos de alta qualidade. Ela é professora da Universidade de Hanze, em Groningen, e ela é presidente atualmente da ACENDIO, que é a Rede Europeia de Diagnósticos, Intervenções e Resultados de Enfermagem. Há 2 anos, a professora trabalhava como chefe de pesquisa em um hospital universitário em Zurique, na Suíça, e além da sua carreira acadêmica, ela também tem um escritório de consultoria, que presta consultoria para hospitais, para instituições de longa permanência, para instituições de assistência domiciliar, a implementar o processo de enfermagem avançado e classificações de enfermagem. Ela também presta consultoria a empresas de tecnologia de informação para a implementação de diagnósticos, intervenções e resultados de enfermagem em sistemas eletrônicos de saúde, com base na classificação NNN. Durante a sua carreira, ela foi membro dos Comitês de Desenvolvimento Diagnóstico e de Pesquisa da NANDA International durante 8 anos. E ela considera que os sistemas de linguagem padronizados não são apenas a sua expertise, mas também o seu hobby. A professora Maria Muller-Staub gentilmente gravou sua apresentação para que nós tivéssemos oportunidade de gerar legendas automaticamente pelo YouTube. É uma apresentação dividida em 2 partes. Infelizmente, por problemas técnicos, a segunda parte não tivemos legendas geradas automaticamente pelo YouTube, mas para a primeira parte vocês terão a opção de ligar as legendas e podem colocar as legendas, inclusive, em português, traduzidas automaticamente. Nós tentamos corrigir as legendas no melhor da nossa capacidade, mas ainda podem ocorrer alguns erros na tradução e na versão também em português dessas legendas. Esta apresentação, portanto, será realizada em 2 etapas. Entre as 2 etapas, nós teremos uma sessão de perguntas e respostas, lembrando que os nossos estudantes dos programas de pós-graduação brasileiros fazem suas perguntas no nosso canal do Telegram, e os pontos que a professora Maria Muller-Staub abordará serão a definição do processo de enfermagem avançado, por que utilizar linguagens padronizadas de enfermagem, trará um modelo de raciocínio clínico representando o corpo de conhecimento disciplinar de enfermagem, trará estudos científicos a respeito do processo de enfermagem avançado, incluindo resultados dos pacientes sensíveis à enfermagem e resultados de estudos utilizando o instrumento QDIL para analisar a aplicação do processo de enfermagem avançado na prática clínica. Trará também um interessante relato de um paciente que ligou para a professora, esclarecendo o que realmente significa na clínica utilizar o processo de enfermagem avançado, e traz estudos adicionais sobre validação e padrões de apoio à decisão clínica do processo de enfermagem. Professor Muller-Staub, thank you very much for being with us. If you want to say a few words, please.
Hello everyone, I'm very pleased that you are here tonight, and we will have time for discussions afterwards. It's an honor for me for the invitation. Thank you.
Thank you. Vamos à atividade. Uma ótima atividade a todos.
Dear Professora Leita de Barros, dear Alba, dear Camila and colleagues of the Rede de Pesquisa en Proceso de Enfermagem. I'm very pleased to share some news about the advanced nursing process with you, and thank you very much for the kind invitation to be part of this very interesting seminar. This is a traditional nursing process. It's shown as a circle with 6 steps. Here it's in German. It's information seeking, problem statement. Step 3 is setting nursing goals. Step 4 is planning nursing interventions, performing the interventions as step 5, and then evaluating the whole process. This is traditional nursing process, and it was widely used in all hospitals in Switzerland since over 30 years. So that's traditional, but this traditional process was also criticized of not being filled with content and not being filled with evidence-based knowledge. So there were rules on how to state this process, but the content was not evidence-based. So what is the advanced nursing process? The advanced nursing process applies valid assessment tools like the one from Gordon or the NNN assessment, which directly leads and links to nursing diagnosis of NANDA International. And now we have 248 validated nursing diagnoses in these classifications. The next phase in the advanced nursing process is setting outcomes, where you can use the nursing outcomes classifications, which is also a standardized evidence-based classification. It presents 540 outcomes. And the next phase is nursing interventions. The nursing interventions classifications has 565 described literature-based interventions, and the next phase then is to evaluate the outcomes as set out by using the NOC or theory-based nursing goals like in the textbooks like in Dungus et al. So this is a short introduction into what was defined as the advanced nursing process. It means there are valid concepts, there are the advanced nursing process phases on the best evidence nursing classifications, and of course it's not a linear process in steps following strictly one to each other. No, it's based on clinical reasoning. You always have to question the students or yourself. Do I have a coherent, a broad assessment? Do I have all data that are needed? Is the diagnosis correct? Is it still valid? Is it still relevant for the patient? Which diagnosis is to be prioritized? You also have to ask, is the diagnosis based on the assessment data? So from the diagnosis you look back. From the diagnosis you look also, of course, forwards to outcomes planning. Which outcomes are relevant for the patients, which are achievable, which NOC indicators will I choose from the, when you have chosen the outcomes, you go into the implementation phase and implement the evidence-based effective interventions that are needed to at best achieve the planned outcomes, and of course to address the diagnosis and to solve the nursing diagnosis. And of course, these interventions must be able to achieve the desired outcomes. So with other words, this phase in the advanced nursing process is constantly questioning, is it still relevant? Is it valid? Is it evidence-based? Is it matching the individual patient situation? So it's a constant circular questioning, and the nurse constantly is required to make decisions based on the clinical situations. We also say in our country that nursing diagnoses are the indicator for the patient's care needs. The outcomes are the indicators that say where is the patient now and where do I want him later at the end of the hospitalization or of the treatment situation. And in the interventions, the nursing activities, the specifically naming sentences telling the nurse what to do with respect to each single intervention. That are the indicators for the interventions. And of course, at in between of the care given, and at the end, before admission to nursing home or to home, back home again, nurses evaluate by having a clear look at the indicators to see if the desired outcomes were achieved. This is the definition, and the pictures are copyrighted, and here you have the definition. You can read it. So the first sentence is the definition of the advanced nursing process. As I said in the first slide, the traditional nursing process was not filled with validated concepts. One could choose or state nursing problems based on their own opinion or meaning, and not based on a standardized concept as it's described in the NANDA classifications, or you could choose interventions in free text, just what you think, more or less meaningful, more or less evidence-based. But now we have evidence-based linkages between the three classifications, and that means the nursing advanced process is rooted in scientifically based classifications. The definition per se does not say you must use only NNN, but everyone who knows the literature is aware that these three classifications are the best research, and the best scientific evidence is in these three classifications. So it's self-explaining that the advanced nursing process has to rely on the NNN classifications. Because only on the basis of this advanced nursing process it serves its own purpose, which is to apply the scientific knowledge being appropriate to the clinical patient situations with defined and valid concepts. So what are nursing classifications? Nursing classifications provide standardized nursing language. And it's more than a language. It's not about how we talk nursing. No, it's how we teach nursing and what the content of nursing as a known profession is. So, with other words, standardized nursing languages describe the knowledge and the body of knowledge of nursing. Standardized nursing language name and describe patients' care needs, effective interventions, and how to measure patient outcomes that are nursing sensitive, that are achieved due to what nurses do. And I was also asked, can every nurse apply the advanced nursing process? I say yes. I mean, each registered nurse with a bachelor's degree level. In many countries, it's in our European countries, it's even in the law, that a registered nurse is accountable for the nursing process. She is the only one educated to state nursing diagnosis, to be responsible for an evidence-based care plan, and for outcomes that are nursing sensitive and where the nursing profession is accountable for. This means in each bachelor program, nurses nowadays are taught about the advanced nursing process, and of course also masters prepared nurses and APNs should use and apply the advanced nursing process. Unfortunately, in many countries, the higher education programs like the master's program have a little bit fallen back into the old medical model and have forgotten what is our own profession and what are the roots and what's the focus of nursing. Also, advanced nurses should use and apply the advanced nursing process, and there are marvelous books out for many years like the Ackley and Ladevik books, who describe also the evidence behind each NIC interventions and also how this advanced nursing process is applied by using critical thinking and clinical decision-making in practice. So, with other words, standardized nursing languages support professional and interprofessional communication. And first, this standardized nursing language is to name the same thing in the same words, to be based in scientifically rooted concepts, and to speak nursing so that other nurses understand it. But of course, when nurses clearly articulate themselves, also other health professionals much better understand us what we mean. It also means without standardized nursing language, no naming, no funding. Then it's also difficult to do research if we don't know which problems we address, if we cannot say which interventions nurses perform, or if nurses can't clearly address or explain which outcomes nurses achieve. I give you an example. Concepts in these classifications are key, because concepts are the building stones of science. Not just a word, a term alone, no, the concept. I give you an example for the concept risk for infection. So in the classification of nursing diagnosis by NANDA International, on the top level there is the definition what the nursing diagnosis is, and I will later go into it. On the next level of the classification, we have, for instance, one of the 13 domains is health promotion, with a subordinate class, health management, and in this class, the nursing diagnosis in effective health maintenance is subordinated. So a classification conceptualizes and defines concepts on the level of broad domains, of a little less broad classes, and the most specific is the granular concept level of diagnosis. Here in the domain safety and protection is one of several classes is named and defined as infection, and one diagnosis, which is a concept, is risk for infections. It also has a definition, not only a title, it has a definition, and it lists risk factors that describes this risk, like chronic illness in diabetes patients, or inadequate vaccination, or insufficient knowledge to avoid exposure to pathogens and other risk factors. This means the concept of risk for infections is extremely important, not only for nursing as a profession, but also for every health professional. So this diagnosis has to be clearly addressed and named and made understandable for all health professionals, and it is also understood by all other health professions, not only by nurses, but nurses play a major role in infection prevention and infection control. And of course, we need about germs and about transferring germs and about preventing infection, because every nurse learns this in the basic training. So, I conclude up to here. I address shortly that what the nursing process is. The advanced nursing process is the advanced, the substantiated form of the former traditional nursing process. It can and has to be applied by each bachelor nurse, but also by advanced nurses. It represents the main core of nursing, is the nursing process, respectively the advanced nursing process, which is nurse's responsibility. And the second part, the very important part in this body of knowledge, are nursing diagnoses, and they are best represented in the NANDA classification. The aims of NANDA are to define the knowledge of nursing and to describe the unique focus of us of nursing as a profession and a science, because nursing is more than tasks. It is not just doing something against infection. It is not just washing hands, using disinfectants. No, it's seeing the risk for infections. It's stating the nursing diagnosis exactly. It's knowing the consequences if nurses overlook the risk of infections. So nursing is critical thinking, is stating diagnosis, is setting goals for desired patient outcomes, and evaluating and constantly deciding and critically thinking. I think most of you know the definition of NANDA, what the nursing diagnosis is. But still, I'm always referring to this in each class because sometimes nurses think they know it, but knowing and understanding sometimes isn't the same. This definition describes like two things. First, it's a clinical judgment. This judgment is the nurse's judgment concerning a human response to health conditions or life processes, or a vulnerability for that response by an individual, family, group, or community. What does this also describe according to Marjorie Gordon? Marjorie Gordon has written, this definition, the first sentence shows clearly it's always dualistic. You have a nurse who is in interaction with a patient or a family, and the nurse states clinical judgments based on knowledge, critical thinking, and decision-making. And the patient or family, what does she see? She has a human response to a health condition related to life processes, related to what the person is, whether she is a mother and is young children, or whether it is a person in pension, or someone, a manager who is just lost his job. So we see the human in a holistic perspective. And nursing diagnoses are clinical judgment about these human responses, seeing the person from a holistic nursing perspective. But these are not only actual problems, we also see vulnerabilities for that response, like being at risk for infection is a vulnerability for infection. And then the second part says, a nursing diagnosis provides the basis for selection of nursing interventions to achieve outcomes for which the nurse has accountability. This means nursing as a profession, and each nurse is accountable for outcomes. When I'm accountable for an outcome, this means I have responsibility, but it also means nursing has outcomes. Don't we have too many nurses clicking in the medical model and thinking, no, nursing doesn't have an effect at all? That is still a widespread meaning, also sometimes in the medical field, that nurses are just doers, you can just hire low nursing staff without good education. We know from ICANN and other studies, if we have a lack of nurses, we have higher mortality, we have higher infection rates, we have higher falls. Patients need nurses who can think, who can see and react on the human response and the human vulnerabilities, and who perform and choose. It says we select interventions. The definition does not say nurses perform interventions that are ordered by someone else. No, the nurse themselves select intervention. And what is the assumption if I select? Selection means I have a broad variety and I am able and knowledgeable to choose from. As you know, the nursing interventions classification has over 500 interventions. We need to choose from what is best for each individual patient or family. So this is a wonderful and a very meaningful definition what a nursing diagnosis is. Each nurse should know the most prevalent nursing diagnosis. It must be a part in each semester of basic nursing training, but also in advanced nursing courses. Because, as described by McCluskey and Polacek from the University of Iowa in the USA in 1992 and adopted by Sue Moorhead in 2013, this is the nursing knowledge and decision-making model. The nursing knowledge model states that these three classifications describe the nursing knowledge or the body of knowledge of our professions. This knowledge is described in the three classifications. The care needs, defined as NANDA nursing diagnostic concepts. the nursing outcomes that nurses can reach by performing evidence-based nursing interventions. So this is a theoretical body of knowledge, or the knowledge of the profession, and these three classifications have the aim to describe the full body of knowledge, all interventions, all diagnoses. And based on my research, on my clinical experience, these three classifications really are broad and capture very many and the most important concepts used in clinical practice and in education. But the theory, the classification, is not all. What we need is the clinical reasoning of the nurse. It always says, you make a choice. You make a choice which interventions, you make a choice which outcomes does this patient want to reach. We make a choice which is the best suitable interventions for this nursing diagnosis in a specific situation. So what was added to the traditional model by Dra Muller, she said, or wrote, the choice is based on a systematic nursing assessment. It's based on diagnostic accuracy. This means diagnosis should really be based on assessment data, and we, in our countries, we ask the nurses have to state also the PES format into the nursing care plan, because this makes really clear for every nurse why the patient has this diagnosis, what are the defining characteristics, how can she see that the diagnosis is really there. And each nursing diagnosis should also, whenever possible, include patient priorities or patient's preferences. In the outcome, in the choosing outcomes, we should consider the accuracy of measuring the outcomes, the accuracy how we say what the indicators or nursing goals, in another term, the patient should and will achieve. And also, of course, we have to document this data in order to get longitudinal data over time today if the nursing diagnosis was acute pain. Based on fracture, I can't really right now by heart say the NANDA term, but if a fracture is behind of this pain, because it says there is something happened, an impact, and then this gives a pain to the patient. So we must say, what is the best outcome, how is it reached, and how will we measure it, and how is it ongoing, and the outcome would be pain level. Patient says, I'm now on a 4, not on a 10 again. So this data should be documented over time, so we have longitudinal data to research, and to then, of course, we also include patients, what does he or she want to achieve. If he or she says a 4 is good for me, then I would be happy I were on a 4 of pain level, and now I'm on an 8. And then, of course, the nurses makes a choice based on which intervention best relieves the pain. And of course, we always have to look on the best evidence. We also have to take into account, is it applicable based on costs, and is it applicable based on the competencies of the nursing staff that we have on the specific ward. And so with this specified data, we then can gain future knowledge based on research, and based on this research, we can create models for care populations. And we already have several studies, and many come from Brazil, which are the most important nursing diagnoses in patients with heart failure. What are the most effective interventions? How were the outcomes reached, and which nursing outcomes were reached? So this model helps us to come up with predictive care based on practice and on evidence. It's a very important model, and I suggest that you use it in your classes. I give another example. For instance, when a patient has powerlessness due to chronic illness, insufficient interpersonal interactions, and because of the institution environment, which might be very much, the doctors or nurses might behave like I'm the boss and not, you have nothing to say. This is sometimes happening in institutions. Then the signs and symptoms or defining characteristics is from the NANDA. Patients is frustrated about inability to perform activities. He feels shame. He expresses signs of depression. Then a NIC intervention addressing the powerlessness suggested linked, it's also evidence behind these linkages, is the nurse could choose self-efficacy enhancement. This is a NIC label, is a definition. And NIC activity is empower the patient to see his own strengths, support the personal strengths of the patient, support seeing positive reactions of others towards he or she perceives the care given or his ongoing progress. Another intervention is mood management, and it again contains many activities which describes clearly what mood management means. Another related NIC intervention to powerlessness is decision-making support, and a list of nursing activities describes how the nurse supports the patient in decision-making. Another NIC interventions linked to this NANDA diagnosis, powerlessness, is being present. And again, these NIC activities, and here I cite a last, but also very important intervention is giving emotional support. Again, this NIC, emotional support, is also described and specified as specific NIC interventions. What does a nurse do? What does she choose to provide emotional support? Which outcomes are achieved by implementing these NIC interventions? One major outcome is participation in healthcare decisions, where a patient first felt powerlessness, where he or she was frustrated about not being able to perform daily activities, was in shame, was showing signs of distress. Now, because he or she is supported by self-efficacy enhancement, by mood management, by decision support, by presence and emotional support, finally the patient shows participation in healthcare decisions. She states preferences, what she likes to do, how she likes things to do. She shows problem-solving techniques, is active again, seeks autonomy, says, oh, no, I want this, I want that. She takes self-reliability, and the person shows personal autonomy. And these are indicators in the NOC. I only chose several, there are more, of course, in the classification, and also for personal autonomy. The NOC outcome classification describes indicators that indicate when a person shows and which grade of personal autonomy a person shows. There's always a 5-Likert scale behind the NOC outcomes. It's the same for hope. Hope is a concept that can be made measurable in the nursing outcomes based on indicators that indicate if the patient is in hope, its person expresses hope, person doesn't show signs of depression, of shame, which is positive again, and says hopeful sentences. So this is one example of one diagnosis with linked interventions and linked outcomes. And I hope this example makes clear a nurse really needs to have in-depth knowledge about these concepts of powerlessness, of self-efficacy enhancement, of mood management, and of the outcomes participation in healthcare, or the outcome personal autonomy. It's not an easy thing. And it's not just a task. It's not a task like giving an IV shot, which is pretty easy compared to these psychosocial concepts. These psychosocial concepts also show what a holistic nursing perspective contains. And really, it's important that also advanced nurses participate in stating diagnosis, in evaluating nursing outcomes, and that they use this standardized nursing language also in electronic health records to make nursing visible. I now come to background about classifications. What do we know from the research? We know SNLs, or this classification, do make nursing visible. They are needed for electronic health records because without standardized concepts, nursing is not retrievable without codes, without concepts. It's not usable in the electronics, in the digitalization systems, and such systems do exist also in Sao Paulo, also in Switzerland, also in some parts of the US. And such electronic nursing care plans provide data for nursing research. However, we also know that these classifications need be better and more thoroughly implemented into nursing curricula and also into nursing practice and in more electronic health records. We also know there are other systems out on the market, like the Omaha or like the ICMP systems. How does the numbers look with nursing diagnosis on NANDA? You see, it started very early, 1986. It's the number of studies are steadily rising, and now the first broad glimpse shows over 500 studies are out on NANDA nursing diagnosis, and there are many validation studies here and many implementation studies and studies on what outcomes are, on what is the quality of nursing diagnosis when applied in practice. It's not just descriptions of how to develop a diagnosis. It's much more. It's reports of having the classification implemented. The same is true for NOx. It's a little less, showing here 202, because it's a younger classification than the NANDA. But you see, one example here is from South America, because your country is very active in this part of research, and this is content validation of the outcome heart failure management in and about Brazilian nurses' opinions. Or here is a small scale average of the efficacy of silver sulfate for burns, specific diagnosis. And what does it mean for the NIC? First, it's not a really in-depth search, in-depth research here. But when you just go to PubMed and say Innovations NIC 331 hits, and one is also with Ravelo Silva and other colleagues, Almeida and Graciela Lynch and myself, advanced, we did a study comparing nursing process quality, the ICMP versus the NANDA and the NIC, and it's a very often cited studies and one of the 300 examples. This clearly shows the NNN are the best evidence and most researched classifications. So in total, right now there are over 1,200 studies that performed worldwide. And primarily it was when you look at the care plans and everything had to be sucked. And nowadays we can withdraw the data from the electronic record, and it's much easier to come up with, to get the data from electronic health records to evaluate these three classifications. And an expert paper, which was published by the Swiss Nursing Science Association and myself, shows several a summary of these three classifications and how they provide best evidence compared to other classifications, and why these three classifications are providing the body of knowledge for nursing as a unique profession. I give some examples, like in school health, there are studies which are the most used: nursing, diagnosis, interventions, and outcomes. This is a study from Achterberg and then from Finland, or another one from Africa, one about which are the most used: nursing, diagnosis, and mix in psychiatry. It was a doctoral thesis of one of my doctoral students, Fritz Frauenfelder. Another example is which are the most used nursing, diagnosis, and outcomes in elder care or in children, and one of the very most seen nursing diagnosis is pain, but there is also in children as a population impaired swallowing, also from Brazilian authors, or another one from from Japan. And another diagnosis is from these authors from, I think this is Spanish study, pain and outcomes in patients with hip replacement patient, a specific group, also a study from Rodriguez et al. From Brazil, another one from Park in the population of heart failure patients, and several studies from your country about the most used NICs and NOCs and NANDAs in heart failure patients. There are also newer articles out proposing the most used and seen nursing diagnosis, interventions, and outcomes in a single patient, but also as a community response in COVID patients. So there is very broad knowledge base on the NNN in literature. So I think I will, after this, show only few slides, and then we make a break so you can ask questions to the presentation up to now. So I summarize the advanced nursing process, which is rooted in these best evidence classifications that would represent the body of knowledge in nursing as a known profession, is needed to make nursing visible. It's needed to be implemented into electronic health records and to withdraw data for big data research. And only a brief overview that I just gave over more than 1,200 studies, which many of these I'm familiar with, and they show, the literature reviews show that the best evidence is in the 3 classifications. But there are other classifications also available, like the FINC. In Finland, they have the clinical care classification. We found 11 studies. We found on the ANAHA, another system often used in home care in the US, showed 46 studies. The ICMP showed 165 most descriptions on the development, and the NNN in total showed over 1,060 studies. So this is just a broad overview of the state of the art about these 3 classifications, which are the basis of the advanced nursing process. Each nurse needs to know the NNN to apply it into practice, to know the evidence behind it, but also how to say diagnosis, how to choose outcomes, and how to link this with effective interventions for patients and families. These are some citations, newer studies, which this are the basis of what I just addressed. A very important study was the evidence based from Tastan et al., but also the Keenan and the Hardike is a newer one coming to the same conclusions. So here I now make a break, and before I come to studies that provide outcomes, and we can then take questions when we are directly